Good afternoon. I'm Abhinav Sood. I'm one of the General Cardiology Fellows at Mount Sinai Beth Israel in Manhattan, New York. I have the pleasure of having Dr. Desai with us today from the Cleveland Clinics. Dr. Milind Desai is the director of the Center of Hypertrophic Cardiomyopathy at Cleveland Clinic. He's also the Haslam family endowed chair in cardiovascular medicine at Cleveland Clinic, and a professor of medicine at the Cleveland Clinic's Lerner College of Medicine. So, welcome, Dr. Desai.
Thank you very much. Thank you, Abhinav, for having me here and giving me the opportunity to talk.
Our pleasure. So, we're finally in-person meeting at ACC 22 at Washington, D.C. Dr. Desai, if you don't mind telling us about the VALOR-HCM trial. I know you presented this today morning, the late-breaking clinical trial session, which was excellent. But for our viewers, if you don't mind telling us briefly about the trial again.
Sure. Thank you so much. So, VALOR-HCM study is a randomized double-blind placebo-controlled trial which studied the novel cardiac myosin inhibitor in the context of severely symptomatic obstructive HCM patients and whether or not it can serve as an alternative or defer septal reduction therapies, i.e. surgical myectomy or alcohol septal ablation. So this study was conducted in 112 patients, randomized 56 to Mavacamten, 56 to placebo, ran for 16 weeks. And essentially what we did was we started patients on 5 milligrams of Mavacamten in the Mava arm, followed with monthly echoes that were measured using core lab echocardiography for EF as well as LV outflow tract gradient measurements. And dose titration happened at 8 and 12 weeks, and at 16 weeks, patients basically were evaluated for their continued eligibility criteria for septal reduction therapy. Remember, 100% patients at the beginning of the study were referred for SRT, be it alcohol ablation or surgical myectomy. So essentially, so these were sicker patients on maximally tolerated medical therapy, including combination therapy as well as disopyramide. All patients had severe outflow tract obstruction, and it preserved ejection fraction. And as I alluded to, everybody was considering and was a candidate for septal reduction therapy. So what we found was essentially, so this was a good population, a representative population, essentially 60 years of age, 50% females, all with severe outflow tract obstruction, 93% patients with NYHA class 3 or higher, 36% on combination therapy, and 20% on disopyramide therapy. At the end of 16 weeks, in the Mavacamten group, out of 100% patients that were eligible for SRT, only 18% continued to meet eligibility criteria for SRT. In other words, 82% no longer met criteria, compared to the placebo where 77% continued to meet the criteria. And the p-value was hugely significant, less than 0.0001. In addition to this, there were also key secondary endpoints tested, and there was a significant improvement in gradients in Kansas City Quality of Life, NYHA class, as well as biomarkers in the Mavacamten group. Importantly, at 16 weeks, every patient was given a chance to switch to an SRT procedure because they, at the beginning, met the criteria. 95% of patients in the entire study chose to continue on medical therapy. So that was an interesting finding that we found. Safety-wise, this was well tolerated. Only 2 patients needed a short-term discontinuation because of a drop in EF less than 50%. There were no patients who dropped their EF less than 30%. Once the EF dropped less than 50%, the drug was temporarily discontinued, dose was down titrated, and restarted and patients continued to do well without any additional discontinuation. And there were no other safety markers. The ejection fraction stayed the same, non-significant between the two groups. So those are the in essence the findings of the VALOR study.
That's excellent. I think this was an absolute reduction of almost 60%? 58%. And just to bring thing again, we previously had another trial with Mavacamten, the EXPLORERHCM.
Yes.
And the VALOR-HCM and EXPLORERHCM, if you don't mind pointing out what the differences among the two were.
Yeah, that is, yes, excellent question. So you heard about the VALOR-HCM, but in contradistinction to that, in EXPLORER-HCM, 72% patients were in NYHA class 2. These patients were not being considered for septal reduction therapy. Combination therapy was not allowed. Disopyramide was not allowed. The follow-up, the titration, the dose titration was based on blood-based pharmacokinetic assessment, a drug dosage, drug pharmacokinetic assessment. Now, the advantage of VALOR is it is more clinically applicable in terms of our ability to follow the patients and be able to provide continuity of care. So that's why we use ECHO criteria. Sicker population, refer for SRT, echo-based assessment, and ability to use combination therapy as well as disopyramide therapy.
Thank you. The other question that I had was, hypertrophic cardiomyopathy in terms of surgical reduction or ablation with alcohol septal ablation. It's usually recommended to do it at centers of excellence, and the centers. This was a multi-centric trial. These all surgical centers of excellence in terms of where this trial was conducted. So that, I guess, in addition, adds on to the fact that Mavacamten is still effective.
Absolutely. So, you raise a very important point. If you are an obstructive HCM patient with intractable symptoms, and if you are lucky enough to have access to a high volume, high quality, very low adverse event, very low mortality center, that's great. It does provide significant symptom relief. It provides improved quality of life, long-lasting LVOT gradient relief. The unfortunate reality is there's not too many such centers around. The second issue is even in so let's think about it in the following different ways. So such centers are not around, not too many of them around. And if you have this procedure at any center, the U.S. National Inpatient Sample suggested that the mortality across the USA was 5.9% after this surgery. Guidelines recommend you go to a center that does less than 1% mortality type operation. 5.9 overall. If you go to a low volume center that does a handful of these a year, mortality can reach up to 16%. So this is in USA where there are centers that do myectomies. What about the rest of the world where access to septal reduction therapy, invasive therapies is certainly not as robust, and the outcomes data is even we don't know. So there is a huge unmet need. Another important math situation here is as follows. Okay. There is a huge need to improve our diagnostic capability of HCM, not just obstructive HCM, overall HCM. And once we identify more patients, we are going to have a bigger tent, which will need a bigger set of tools to help these patients, including newer drugs. So I think that's how we need to look at this. Science begets progress.
And another question about the population group that was enrolled. I think inclusion criteria, most of the patients had to be the septal thickness was 1.5, or if it was 1.3, they had to have family members and couple episodes. were there any patients that had isolated caudal obstruction or valvular mitral valve?
So thank you. Yes. So for this trial, for the drug that we are testing, this is a cardiac sarcomere myosin inhibitor type drug. So we obviously chose the population where those kind of the atypical variants of HCM is what I like to call them, the folks with abnormal papillary muscles, chordae, mitral valve. Those were not included in the current study because that's a slightly different problem, and it may work, who knows, but especially for this trial, that was not deemed to be the right population to study.
Thank you. And in terms of the outcomes that were studied, you pointed out there was an objective endpoint in terms of the gradient, as well as subjective endpoint in terms of the KCCQ improvement, and NYHA as well. So assessing and targeting both objective and subjective endpoints.
And that's how you practice. So it is important. We cannot just be reliant on numbers to treat patients. You have to treat patients. And in order to treat patients, you have to look at the patient, you have to understand their symptoms, you have to understand their quality of life, you have to understand what the numbers are, and then you have to put everything in context.
In terms of follow-up, you pointed out as well, this was 16 weeks of follow-up, and can we expect longer-term follow-ups coming up as well?
Yes, absolutely. So this was 16-week follow-up, and at 16-week, as I alluded to, we offered SRT to all. 95% of them did not choose to. So these obviously are going to roll into the long-term extension arms of the current study. And, what I will be interested in looking for is as follows. Is it safe in the not only short term, but in the long term? Is it efficacious? Are we going to continue to convince people to stay on this drug and avoid going for a invasive procedure? All these things time will tell. Or will we have a distinct group of people that they say, I'm happy with this? There's a distinct group of people say, I was happy with this. Now, you know what? I want surgery or a procedure. There's another group is, I could have surgery, but I'm just too high risk, or my anatomy is not conducive. And the fourth group is, I just live in the part of the world where I just do not have access to good quality care. So different strokes for different folks. I guess where you fit in is how this will evolve. The story will evolve.
And in your experience while conducting the trial and the combined experience of the entire trial team, any particular side effects or adverse effects that came out with the use of Mavacamten in particular?
So the big hoopla has always been around ejection fraction drop. And in the context of the VALOR-HCM trial, it did not appear. That doesn't mean that it may not appear in the long term. We don't know. We have to study that. Otherwise, there were no other major side effects that popped up that would raise any cause for concern.
In terms of accessibility to this drug, I think Mavacamten is still under FDA review, but do you think this would definitely, most likely help in getting Mavacamten through? Because the trial outcomes, almost 58% absolute reduction, no major safety endpoints in the short-term follow-up period. I think we would have more access to the drug, hopefully.
Well, I certainly do not work for the FDA, nor can I read what's in their mind. But there is a PDUFA date. There is a approval meeting coming towards the end of April 2022, and they are going to evaluate all the data and then decide how to proceed. My assumption is that it is going to get approved. There's a fair bit of robust body of evidence to suggest that should be the right approach, but you still have to see that process through. And once that process is through, then becomes the logistics of drug delivery and supply chain and cost and all those things that will come into play.
Well, thank you, Dr. Desai. I think congratulations again. This was an excellent trial. I personally enjoyed this morning's presentation a lot when you presented this.
Thank you so much. And it is indeed a pleasure to be doing this Fellows in Training thing. It is awesome. Thank you. Best of luck.